starting, but we will make up for that lost time at the end. So again, welcome. My name is Wayne Musabayana, and I am joined, as usual, by the director of the Africa CDC, Dr. John Nkengasong. We also have an announcement to make, and that is that in order for us to bring you content that is coming from all over the continent of Africa, we will be bringing you someone from an AU member state. We have 55 member states. So starting from this week, we will be having a representative of a member state talking to you after Dr. John gives his brief. And this week, we are glad to welcome Professor Lynn Morris, and she is the Interim Executive Director of the National Institute for Communicable Diseases in South Africa. We will welcome her when she comes to join us. But let us start with a brief from Dr. John Nkengasong, the Director of the Africa CDC. Dr. John.
Thank you, Wayne, and good morning, colleagues. Good morning, collaborators. First of all, let me commend the efforts of healthcare workers and community workers in their tremendous and heroic efforts in supporting the COVID-19 response across Africa. These are the people that protect us, and as I've indicated previously, we have to do everything possible to ensure their protection as well. Secondly, I would like to emphasize that our pandemic has gathered pace and is increasing rapidly, as we'll go through the numbers shortly. As such, I would like to emphasize that we need to increase our compliance to public health and social measures as we've recommended, and as well as the World Health Organization, because we do not have a vaccine, neither do we have a cure for COVID-19. Especially at this moment where we are beginning to have uneasing of the lockdown measures that were applied across the continent. I'd like to emphasize that upfront, and I will come back to that later. Let me just transition to the epidemiological situation on the continent. First of all, globally, as we speak, the world has recorded about 13 million cases of COVID infection with nearly 600,000 deaths. In Africa, 54 countries have reported a total of 644,000 cases of COVID-19 infections, of which about 14,000 people have unfortunately died on the continent, resulting in a case fatality rate of 2.2%. The good news is that there have been about 330,000 individuals that have recovered from the COVID infection in Africa. So if I compare last week when we met and this week, the overall trend suggests that we have observed a 23% increase in new cases, which translates to about 119,000 new cases reported from last week to this week, and with a daily average of about 17,000 cases reported per day. And if you recall, last week we had around 14,000 new cases a day. 5 countries account for 73% of all cases in Africa, and they include South Africa with 311,000 cases, and I'm sure Professor Lynn Morris, a long-time colleague, friend from South Africa, will be giving you more details on this. And that represents 48% of the cases, total cases on the continent, followed by Egypt with 83,000 cases representing 13%, Nigeria 34,000 cases representing 5%, Ghana 25,000 cases representing 4%, and Algeria 20,000 cases representing 3%. Our testing continues to improve on the continent. As of yesterday, or this past week, the Africa Centers for Disease Control and Prevention had distributed 3,600 gene expert cartridges to Chad and Lesotho, as well as enzymes for about 240,000 tests. Overall, as of yesterday, the continent has conducted 6.5 million tests, representing an 11% increase over the previous week. This takes us closer to our PAC target of 10 million, which we announced a couple of weeks ago. PAC, of course, is a partnership to accelerate COVID testing in Africa. It is important to note that 10 countries contribute about 80% of all the tests, and this includes South Africa, Morocco, Egypt, Ghana, Ethiopia, Uganda, Kenya, Mauritius, Rwanda, and Nigeria. The Africa CDC continues to mentor laboratory experts on genomic sequencing in 3 member states, that is Ethiopia, Senegal, and Nigeria. If you recall, last week we announced the launch of a consortium for COVID-19 vaccine clinical trials, in abbreviation CONVAC. And this week we have already, as part of that consortium, begin to engage vaccine manufacturing companies to explore partnerships with them. It is a strong belief that Africa should play an active role in the process of development of the vaccines and uptake of the vaccines, and not wait until vaccines are developed before we distributed in Africa. So we are positioning the continent to play a coordinated role to enhance and accelerate the clinical trials of any promising vaccine candidates on the continent. As of the 12th of July 2020, we have recorded about 64 clinical trials being taking place in Africa, not vaccine trials, but clinical trials for drugs. In the past week alone, Africa CDC has deployed an additional 16 experts, including 9 epidemiologists, 5 laboratory and 2 risk communication experts to Malawi and Chad to support their COVID response efforts. And Africa CDC is inviting you to join us on July the 22nd at 9 a.m. East African time with the World Health Organization office in Afro for the launch of the Regional Expert Advisory Committee on Traditional Medicine for COVID-19 Response. Again, the date is July 22nd at 9 a.m. East African time. The African Medical Supply Platform, in abbreviation AMSP, which we announced, a common platform to ensure that we have access to commodities necessary to respond to COVID-19, is active and functional. It is my pleasure to announce that 20 countries have already boarded this platform, and they are at very different stages of completing their procurement. It is also my pleasure to let you know that 600 suppliers from all over the world are now contributing products on the platform, and with many of these suppliers from Africa. Let me just conclude again by emphasizing what we must do as a continent as we unlock our economies. First is to increase our pace aggressively as we implement the PAC initiative, which is a partnership to accelerate COVID testing, which is underpinned by ability to test, to trace, and to treat. We need to ramp up testing. We need to trace those who are infected and isolate them and make provisions for appropriate treatment. The second thing we must do is to engage communities very actively. The battle against COVID-19 is that will be decided at a community level, and without proper community engagement, community ownership and response, we will not be able to conduct the appropriate contact tracing and care. And lastly, we are calling on all countries in Africa, member states, to ensure that we have a policy of universal masking. That is, we should all wear masks when we are in public places there. I think there's now plenty of evidence to show that mask wearing all the time, especially in places where public places, decrease transmission. Thank you.
Thank you very much, John, for that comprehensive brief. As we mentioned, colleagues, we are joined today by our very first representative of member states of the African Union, and the representative is coming from South Africa, and she is Professor Lynn Morris, who is the Interim Executive Director of the National Institute for Communicable Diseases, NICD, in South Africa. Professor Lynn, are you with us?
Yes, I'm here.
We can hear you very well, Prof. Please go ahead.
Thank you very, very much for this opportunity, and thank you, John. Night and day to try and mitigate the effects of this pandemic. As John mentioned, South Africa has now over 300,000 confirmed cases, and we have 4,453 deaths, very unfortunately. South Africa's epidemic has shown some regional variation. So the first case, as I think many people know, was reported on the 5th of March in Johannesburg, but in actual fact, the epicenter of the epidemic, certainly for the last few weeks, has been in the Western Cape, in Cape Town. In that province. The epidemic has since shifted now, and we've seen rapidly rising epidemics in the Eastern Cape and now in Gauteng, which is where Johannesburg is based. And so we're starting to see a ramp up in those two provinces as well. One of the things I think that is characterizing the epidemic in South Africa, and it's true in many countries in Africa, is the low case fatality rate relative to the case rate. And I think that's something that really requires more investigation to try and understand. Our current death rate is around 2%, it varies around 2%, which is considerably lower than many countries in Europe. And I think it's something that we really, as a continent, is something that we really do need to try and understand better. Obviously, it's one of thankfully it is, those rates are lower. And then in terms of the testing, so South Africa has done 2.2 million tests, both in the private and in the public sector. And that's obviously contributed a lot to the tracking and tracing system. We've just implemented a tracking and tracing system as well in some of the provinces. And this will be obviously important that the turnaround time for these tests is quick in order to enable the tracking and tracing to be effective. I'd also just like to really touch on a subject that's very dear to my heart, because I come from an HIV background and an HIV vaccine trial background, and that is the importance of developing a vaccine. As we all know right now, we have behavioral interventions to try and limit the spread of this virus, and really what we do need is a preventative vaccine to really get on top of this epidemic. And I think it is important that Africa plays an active role in this process, because we know that vaccines vary. They have different levels of efficacy amongst different populations, and we as a continent want to be part of the development of the vaccine, so that when one becomes available, we will be able to deploy it as soon as we can. So just to say that South Africa has really embarked on a vaccine trial. It's the Oxford AstraZeneca vaccine. It's a chimp-pad vaccine, so it's a vector vaccine. And that trial started a couple of weeks ago. And because of the high rate of enrollment, but also the high rate of infections that we're seeing, we're actually expecting to get the results of that trial earlier than anticipated. But just to say that this is for phase 1, phase 2A trial, so it's a safety trial. Because safety is the most important thing right now, because I think one of the things while we all recognize that vaccine is an urgent thing, we obviously have to ensure that this vaccine is completely safe before it is rolled out. And so safety will definitely be the most important thing. Just to say as well that South Africa is still has some restrictions. Additional restrictions imposed in South Africa. We did have a more general lockdown. It's slowly been easing, but we do still have some restrictions and also mandatory mask wearing in South Africa for everybody, and obviously a real emphasis on behavioral. Thank you very much.
Thank you very much, Prof, for that brief coming from South Africa. We are now going into our question and answer session. And before I give my first question to Dr. John, let me just remind colleagues who may want to ask questions that for our Q&A session, you are requested to send your questions to the WhatsApp number +251 945 502 310. That is +251 945 502 310. Please do give us your name and the institution that you represent. So that is one way of putting your question across. The second is that if you want to engage and ask your question live on screen, kindly write your name and institution in the chat section of the screen, and you will then be acknowledged to ask your question directly online. We move on now to our Q&A session, and we start with someone writing us from Malawi. And his name is Luciano Milala from Malawi, working with Mudziwatu Community Radio Station. Mudziwatu Milala has 4 questions. I think I'll give you the first 2 and then we'll move on to the next 2. So the first question is that it seems cases of COVID-19 are still rising in Africa, and it has been shown that lockdowns help to reduce the spread of COVID-19, but because of politics, some African countries, like my own country, Malawi, are denying lockdown to the extent that some courts are giving injunctions to stop the implementation of lockdown. What is your advice to such countries like Malawi, where cases of coronavirus are rising at a fast pace? That's the first question. The second one is that in terms of resources, how much is needed in Africa to end or reduce the spread of COVID-19? So we'll start with those 2, and we'll come on to the next 2 questions.
Thank you, Luciano, for making time to join this press conference, and we appreciate all the partnership with the media and the important role you continue to play in explaining the situation to the community and making sure that the correct information is transmitted. With respect to the rising numbers, we have always said in this forum that we had a delayed pandemic. A delayed pandemic because our continent was one of the last to receive imported cases of COVID-19. We are very careful to make sure that we did not interpret the low numbers that we had to mean that the continent had been spared of this pandemic. And now we are seeing that the virus is seeding itself into different communities, and we are seeing a rapid increase in number of cases. I must say here that our pandemic across Africa, as expected, is very heterogeneous. As I indicated earlier, there are 2 countries that carry a huge number of cases. South Africa, for example, as you heard from Lynn, carries about 48% of the total cases in Africa, and then Egypt, another extra about 90,000 cases there. So it's not. So if you take the Southern African region, the SADC region, and South Africa is on the other side of it, and then most countries that have a relatively low number of cases there, but they are all increasing. Increasing. So I think we should make sure that we note that. Secondly, is that the lockdowns were very instrumental in blunting the pandemic, very early on. But we cannot remain on lockdown forever. You don't fight a war by retreating and staying behind closed doors. You have to go out and fight the enemy. Which the analogy of that is to say that it is not a choice between saving lives or saving the economy. It is a choice between how we save lives and save livelihoods at the same time. So I think countries have to unlock their economies, but do that safely. And we, as well as the World Health Organization, have provided guidance on how to ease the lockdown in a safe manner, and also assess that progressively, and if the measures are working, and if need be, you do additional lockdowns. And I think I strongly urge all member states to follow the guidelines that we issued. They are on our website, and including the media should look at those guidelines and help us promote them in countries as much as possible. In terms of resources, there is the African Union as a whole developed a coordinated approach headed by President Ramaphosa in his capacity as the chair of the African Union, has done a remarkable job in managing this coordinated approach, which means there is a coordinating committee of ministers of finance, there is a coordinating committee of ministers of health, and coordinating committee of ministers of transport. He's also appointed special envoys, financial envoys, who are out there looking for, negotiating for debt relief and debt standpoints, and for us to allocate that, for countries to allocate that money to supporting the COVID response, and also bringing back our economies. I think that is very, very, so countries, it's fair to say that a lot of the countries have benefited from these efforts, and there should be enough resources in country, at least in this initial phase of the response, to support the commodities, access to commodities and testing that are critical for us to respond to this terrible disease.
Okay, thank you very much. I think I'll go on to a question from Sophie Mkwena from SABC, because it is also related to the third question from our first journalist. So Sophie says, countries such as South Africa have seen numbers increasing in communities, but at the same time, we have seen the reopening of schools. The World Health Organization has warned against the reopening of schools where there are growing community infections. Your reaction to this? So that's from Sophie, but a related question is that most of the schools in Africa are still closed due to COVID-19. When do you think would be the best way to open schools?
So thank you, Sophie, for that very important question. I mean, like I indicated in unlocking our economies, I mean, schools are also part of the society, and that needs to be taken into consideration. We cannot keep our children out of school forever. We have to also develop guidelines and policies that will guide us and countries to open schools safely. That is very, very important, and do that progressively. I mean, and we have, and borrow from experience, and observe that and evaluate it over time. I think we saw that from experience, that what Israel did, they opened up schools quickly, and infection started occurring. They had to shut down that. We have to be very mindful of and be disciplined that if a country like South Africa is opening up schools, they have policies, they have procedures in place that will ensure the safe opening of the schools as much as possible. Many schools are still closed on the continent, but it is my speculation that it will not be long before schools are open. It is also possible that because we are at the end, in many countries as well, we are at the end of the school year, that they will delay it until and observe the situation for the next academic year that starts in August or September. So I think it will be a country by country basis there, but there are guidelines that are out there which are either developed by us or the World Health Organization, that we strongly encourage countries to look at those guidelines and use them and customize them in the context of their countries.
Thank you, John. We move on now to Coletta Wanjohi, and Coletta has 3 questions. The first one is, how many COVID-19 vaccine trials are currently ongoing on the continent, and what is the progress? That's 1. The second one, what is the response so far of African countries on the Consortium for COVID-19 Vaccine Clinical Trials? And then the third one, what is the progress so far on Africa's own efforts to produce its own vaccines? That's from Coletta Wanjohi.
Thank you, Coletta, for those very important questions. And I'll respond, but I'll also invite Professor Morris to weigh in as well. For the first question, to the best of our knowledge, there is Africa CDC's knowledge, we have 1 trial taking place in South Africa, which as Lynn would if she wants to elaborate, and she can touch on. So that's the only trial that we are aware of. With respect to the reaction to the CONVAC, which is the Consortium for COVID vaccine clinical trial, it has been massive. I think many countries and many partners want to work with us on this, and we are moving full speed by, as I indicated, engaging with the vaccine manufacturers already to seek their interest to partner with us. On this point, let me just be very clear that we want to approach this as a continent and avoid a scenario where individual manufacturers approach countries as such to do that. We are not seeking to control efforts from different countries or the vaccine manufacturers, but we seek to coordinate. Again, the underpinning of our continental strategy is around cooperation, collaboration, coordination, and communication. We want to ensure that this is actually applied across as we work on the vaccine issues. As Lynn would mention, it's a complex issue to develop vaccines. It's a complex issue even to uptake for uptakes of vaccine. It's a complex issue to engage with the community. So I think we want to be sure that Africa CDC is pulling all the networks on the continent and the right partnerships to ensure that we fulfill that. With respect to Africa's development of vaccine as such, I'm not aware of any group that has announced a breakthrough for vaccine that we have seen on the record. There are certain announcements that have been made, I believe, in Nigeria, and we are following up on that as well. Now, there's 2 things we have to take note of, actually 3 things. One is we are encouraging local manufacturing of vaccines, which means if we have a good candidate vaccine or a vaccine that has been proven to be successful or effective in any country, we are asking for intellectual property transfer so that they can be manufactured locally on the continent. The situation with COVID vaccine is an interesting one, because if there's an available vaccine today, about 7.8 billion people in the world will be in need of that vaccine. So that manufacturing will need to be decentralized as much as possible. And we are very confident that there are groups on the continent that can manufacture, which is different from producing a vaccine, which means you're doing your own research on it and then producing, find a candidate, test it, and make sure that it works. Then you take it to clinical trials. I think that is something that can be done, but in an emergency, we are saying any vaccine that is promising anywhere and shows promise, we can test it on the continent as much as possible. Lastly is the clinical trials. We want to be sure that the sites are ready. So, for example, if the Oxford vaccine that Lynn mentioned shows promise in South Africa, how can we expand that in several other places across the continent? Given the diversity of our continent, it's a continent of 1.3 billion with 55 countries with all the kind of differences in genetic makeup. So we want to be sure that we are participating fully on it.
All right, thank you. We will invite Professor Lynn just now, but I just want to tell you of another question, related question that also came from Sophie, and she's asking about progress being made by institutions that are participating in the vaccine trials. I know you spoke about member states, but in terms of institutions in Africa or elsewhere, what is the progress on that?
Institutions in Africa?
Or elsewhere.
So again, the whole purpose of the CONVAC, which is the Consortium for COVID vaccine trial, is to engage others. For example, this afternoon I will be in discussion with the Gavi, the CEO of Gavi, Dr. Seth Beckley, to discuss exactly how we as a continent can engage with their efforts, the COVAC efforts that they are developing. And secondly, we are in discussions with CEPI, the Coalition for Epidemic Preparedness Innovation, to find ways that we can work together. So I think we have to build these relationships, and as we move on. The institutions in Africa, we've already done a desk review of what clinical sites are available. There are over 80 potential clinical sites, which means they have the ability to enroll participants and follow them carefully. That work has been done already. So I think we are trying to move this as quickly as possible and bring the partnerships. The governing structure is being finalized, which will include co-leads, and then you have a group of stakeholders, the advisory committee, and then technical working groups there. Once that is all finalized, the entire vaccine strategy will be launched once it has been endorsed by the Bureau of the Head of States.
All right, thank you very much. Prof, let me give you 2 to 3 minutes to respond or make a contribution to any of those questions.
Yes, thank you very much. So, yes, I also, right now in South Africa, it's just the one trial that's actually started, but there are a number of discussions ongoing to conduct additional trials. And I think it is important that we do pursue as many of these, promising options as possible, because, vaccines have a high rate of failure. And so we really do need to have a multiple-pronged approach to finding a vaccine. I think one thing that's worth highlighting is, Africa and of course South Africa as well has a very highly developed network for testing HIV vaccines. And a lot of that experience is proving to be very useful in terms of thinking about testing COVID vaccines. So we can rely on both the clinical infrastructure, also the community awareness about vaccines is there. And also the laboratory capacity to test the vaccines, because I think that's another very important part. As a continent, we also want to be involved in the assessment of these vaccines, and so that we can really contribute meaningfully to finding a vaccine. I think another very important aspect John touched on is the manufacturing, and that is something that I think we really do need to, as a continent, we need to build, because there's going to be huge demand for a vaccine when one is available. And of course, we as a continent need to be able to produce and manufacture our own vaccines. So I think that's something that we really should, we should think about. And then, there's the very important questions of who gets vaccinated, and there's, I know, lots of discussions at many levels at Gavi and CEPI around access and equity to make sure that really the vaccines get to the people who need them most. And of course, in an ongoing epidemic, it would be the healthcare workers primarily who would be prioritized in terms of getting a vaccine. I also don't want to run ahead of myself right now, because we're still in the very early stages of vaccine development. And as I mentioned, vaccines, it is a complicated process. As many of you know, we don't have a vaccine yet against HIV, despite a lot of effort. And so, right now there's a lot of optimism, that we'll be able to develop a COVID vaccine. But of course, we don't have any solid data yet. What we do know is that the vaccines that are being tested, and there are over 150 that are in development. I think right now is around 30 already in human clinical trials. What we do know is that they are immunogenic. They are stimulating the right kinds of immune responses. Whether those immune responses are protective or not is obviously what we need to assess. So there's a lot of work ahead. It's not a shoo-in. It's not a definite. People are very optimistic because of a number of things about the virus. One is it's genetically very stable, unlike HIV, which changes all the time. and also because the vaccine so far have produced the right kind of immune responses. So there is a lot of optimism, but at the same time, I think we need to get the evidence and the data to really know for sure, where this is headed. Thank you.
All right, thank you very much. We move on to someone who's joining us live, and that is Joseph Abuja of Africa Science News in Kenya. Good morning, Joseph. Hello, Joseph. Joseph, please unmute your microphone so that we can hear you. All right.
Hello?
Hello, good morning, Joseph.
Morning.
Fine, thanks. Please go on with your question.
Okay, my question was, our country, Kenya, we have had some areas being locked down. And the infection, we have seen the president lifted the lockdowns, he allowed the movement of people around the country. But we have seen the trend of infection even going higher. So does it mean maybe that something's not being done right to curtail the infection of COVID-19?
Can I? Yeah. Good. I mean, thank you, Joseph, for your contribution again this week, as always. There are two things we have to note. One is that as our testing increase, we'll find more cases. I think if you test more, you'll find more. I think that is one. We have to always remember that. Second is that as we unlock our economy and people move around, you will see the increase in infections. The most important thing, as Lynn has said, is that and I indicated in my closing remarks, is to intensify our public health tools that we have in our hand. That is, ramp up testing, make sure that we increase contact tracing, that we social distance as much as possible, and wear masks. Those are the tools that are available in our toolkits, and we have to use those tools effectively. For now, without a vaccine, without treatment, that's all we have. So there's not much you can advise countries to do other than to say that they should decentralize testing as much as possible, but increase the turnaround time so that the testing is not done as if it's a malaria test or an HIV test where you can do it and then return after 2 weeks and get the result. But you reduce the time between the collection of specimens to when you return the results to the patient and you act on the results. I think that is the most important thing that needs to be done with testing. It's not the number of tests as such, but what you do with the test results.
Okay, thank you. Can we now hear from Roslyn Sachiti? And Roslyn is with the Herald newspaper of Zimbabwe. Roslyn? Roslyn, please unmute your microphone.
Thank you. The issue of community transmission, we found out that some people have become so tired and fatigued by the lockdown in their countries and no longer wearing masks, no longer just take all those precautionary measures. And I've seen that in many other African countries. What can African governments do to ensure that this fatigue does not creep in? And at the time, we're also having a spike in the number of cases.
Did you get?
No, it was broken.
Roslyn, can you come again?
Okay, I'm saying I want to know how government can just deal with minimizing local transmission at a time people now have lockdown fatigue and are no longer wearing masks, especially people who densely populated areas. A lot of people are holding up masks on. But at the same time in Zimbabwe, we're having a high number of cases of local transmission coming in.
I think, let me attempt to answer that as best as I can, because again, the quality is not the best. I can, the way I understood it is that there's local transmission going on, and then countries or communities are getting tired of social distancing and wearing masks. My appeal to everyone, as I indicated earlier, is that this battle against COVID, first of all, we are in for a long journey. Okay, I mean, even with the available of a vaccine, access to that vaccine will take time. So I think what we still have in our toolkit are the measures that are indicated, and it requires strong community response, strong community leadership, and strong community ownership. I think those are key ingredients that countries should invest in building that relationship, the trust between government and the community, so that these measures, so that the community members understand why they are having their masks on, why they are calling for social distancing, that way they can participate fully and understand what is at risk, okay, if these measures are not implemented. If the measures are not implemented, we'll even be in for a very long haul. But if the measures are implemented, as we saw in other countries that have successfully fought and won this battle, for example, Japan, Singapore, and other countries, and New Zealand, and Mauritius, right? There will be, then we have a chance to fight and win this battle. So again, strong community ownership, strong community engagement, strong community response is the cornerstone of our for us to defeat this virus.
Thank you very much, John. We move on to Mark Schenkel, and Mark has a question for Professor Morris. Mark?
Yes, good morning, thank you.
Morning, please go ahead.
Mark, morning, yes. Professor Morris, how do you explain South Africa's relatively low case fatality rate?
Yes, Mark, that's a very good question. The short answer is we don't know. Obviously, we're very thankful that is the case. But obviously, when we did the models to predict the deaths, we planned on that, and so it's it is really important for us to understand. And so that when we plan for, when the epidemic really takes off in other parts of the country, that we can plan correctly. There have been some hypotheses. One of them is that, we do have a younger population in Africa in general, and of course in South Africa, and we know that this virus, age is a major risk factor for death for this virus. So that is certainly one potential factor. The other factor is that we are, in terms of the global epidemic, Africa is, as we all know, is behind the sort of the wave, and that we've had the opportunity to implement some of the clinical interventions or improvements, including dexamethasone, which we are using in South Africa, and that may have played a role. Of course, the other thing about case fatality is in relation to the number of cases, and we have done a lot of tests in South Africa, as I said, over 2.2 million, and so that would, of course, also, of course, that's an artificial kind of measurement because, the testing is dependent on your lab infrastructure. But, it could also just be the large number of tests that we've done. So it is something that we definitely need to investigate. Of course, there are lots of other, I guess, sort of less solid hypotheses out there that also need to be I guess, investigated to some extent. But, I think right now also the focus really does need to be on trying to preserve or to keep these low death rates as the epidemic starts moving through the rest of South Africa, and we hope that remains. Thanks.
Thank you very much for that. We have questions. Do you want to make a comment?
Yeah, maybe I just add to that the low death rates is not only in South Africa. If you listen to the numbers I presented this earlier on carefully, I said there were about 644,000 cases as of today, with 14,000 deaths. And it's very important to note that these deaths are very skewed to two countries. Egypt has recorded about 4,000 death cases, and then South Africa about 4,400 cases there. And then a distant third is Algeria with about 1,000 cases there. So if you combine just South Africa and Egypt, they are accounting for 8,000 deaths of the 14,000, which is more than half of the entire continental deaths there. So the caveat here, as Lynn said, is that are we counting everybody? Okay, because of our fragile and weak mortality surveillance systems, is it possible that we are not counting all the deaths in the community appropriately? We just don't know. We are only 6 months into this pandemic on our continent, 6 to 7 months. So there's still a lot that we are learning from it, and still a lot that we need to put in place to capture everything that we need to know about either the number of testing, the prevalence, and the mortality.
Our next question is coming from Tamar Khan, and Tamar is with the Science and Health. He or she, Tamar, is the Health and Science writer for Business Day in South Africa. And Tamar has questions both for Dr. John and Professor Morris. The one for Dr. John: what role do you see for pooled testing for COVID-19 in Africa? And then the one for Professor Morris is, can you comment on the feasibility of pooled testing for South Africa, given the current state of its epidemic? We'll start with you, Dr. John.
No, thank you. I think pool testing is a known technique that we've used in other infectious diseases, where essentially you collect specimens, say, from a certain number of people, bring them all together, and then test, and then you decide if that collection, or we call it pool, is positive, then you unpack it, and then you do additional testing one by one. So I think that is known. However, you have to be sure that the prevalence of the disease is at a certain level in the country. So if the prevalence is high, that is the number of people infected at every given moment is high, then pooling becomes very complicated, because you do very large number of tests and then redo it again. So that if your numbers are low, then pool testing, as Ghana started doing, makes sense to implement that. Let me just add something here and say that we are very early on in even developing the right tests for COVID-19. The dominant test that that is driving the testing now is what you call the PCR based test. That is the polymerase chain reaction test. Is accurate. Is sensitive, specific, but it requires a lot of multiple steps and is difficult to decentralize. We are hoping that with time, and I'm hoping that within months, we'll have antigen-based tests, which will measure the proteins that the virus will produce, called the antigens. And that way, you can easily decentralize the test into the community and decrease that turnaround time. Remember, I'm insisting on the turnaround time, which is defined as the time which you collect the sample and then give the results back to the patient, because that is what is going to be critical and determinant in following up the patients that are positive, isolating them and tracing their contacts.
Prof?
Yes, so thank you for that question. So pooling is, as John mentioned, a very standard technique to really also save on your reagents, because if you pool, for example, 10 samples together, you're only doing one test, but you get 10 results, assuming they're all negative. Obviously, if more samples, as more infections are happening, or you're testing groups of people that have higher rates of positivity, pooling actually becomes, in fact, counterproductive, because you have to go back and test them more individually, so you end up doing more tests. But pooling is a very useful strategy in low prevalence settings, and certainly we were doing it in South Africa when we had a community testing program where the prevalence was very low, and pooling was very useful because, as I said, it saved reagents, it saved take time. It meant faster turnaround times for results. So very useful. But actually, we have stopped using it now in South Africa because our testing strategy is focused now on the high priority tests, and those are people in hospitals, healthcare workers, people in old age homes, or people with comorbidities. And so we really stopped the pooling for now. If we do go back to more community testing, maybe when the epidemic starts to come, the curve starts to come down, pooling may well be introduced at a later stage. Thank you.
Thank you very much. We go back online, and let me call upon Sarah of DEVEX. Sarah Jerving. Hello, Sarah.
Sorry about that. Thank you for taking my question. I'm just wondering if you can talk a bit more about what the role of Africa CDC is in Tanzania's response and kind of what the coordination relationship is. And then also, I've heard that the Ministry of Health is providing alerts to people, kind of like organizations like WHO. I'm wondering if Africa CDC is also creating alerts, and what defines alerts if it's not caseloads.
Did you catch that?
I didn't.
Sarah, can I ask you to speak just a little bit louder?
Oh, sure. Sorry. Can you hear me?
Yes, we can hear you now.
Okay, sorry about that. So I am wondering if you can talk a bit more about what the role of Africa CDC in Tanzania's COVID-19 response, what is kind of the coordination relationship. And I've also heard that Tanzania's Ministry of Health is releasing alerts to WHO. Is Africa CDC receiving alerts from the Ministry of Health? And if so, kind of what defines an alert? Like what's included in alert if it's not an actual kind of case number count? Thank you.
No, thank you. I mean, in terms of coordination, let me respond this way, as I've done before. I mean, Tanzania is an important member of the African Union, one of the 55 member states, and we all agreed on the need to have a joint continental strategy that is underpinned by coordination and cooperation, and coordination, and of course communication. The communication piece is that releasing of the results in a timely fashion or reporting to us as much as possible. Tanzania, the Africa CDC is a member states organization. I think this all through the wisdom and the vision of the head of states that they decided to create a specialized public health agency for the continent. So we expect Tanzania to be an active member and to comply with all the commitments and engagements that as a member of the African Union they are entitled to. So with respect to the release of the results, we have not yet received those alerts, so it's difficult for me to comment on things that we have not seen. So we will continue to, as I said, actively engage with Tanzania, encouraging them to interact with their own organization, which is Africa CDC, as much as possible. It offers a two-way traffic, that we also identify areas that we can provide technical assistance to Africa CDC and to Tanzania from Africa CDC in several areas of response, testing, and infection control, prevention, and surveillance, and others. So we are extremely open to engaging with the authorities in Tanzania at any time.
Cara Anna from Associated Press has a question for Prof. Morris, and she says, what is the average turnaround for a result of the tests now in South Africa, especially in Gauteng and in the Eastern Cape? And what, if any, are the concerns around testing in South Africa? So those are two questions for you, Prof.
Yes, thank you. Very important questions because turnaround time is critical for these tests to be of use. If we do contact tracing, we need to get that result out quickly so that contacts can be confirmed. And obviously for hospitalized patients, a test means that once they're confirmed, they will then be put into a COVID ward rather than waiting and being potentially exposed while in hospital. If they're actually negative, you want to get them put into other wards as quickly as possible. So the turnaround time is really a critical factor. The turnaround times are, for it to be effective, within 48 hours or 72 hours, ideally 48 hours for the test to be, for the results to come back. Some labs are doing it within 24 hours, which obviously is ideal, but as the numbers ramp up, that gets much more difficult. So the turnaround times also vary a lot between provinces, between laboratories, and also between the private and the public sector. There's quite a lot of variation. And that speaks a lot to, just the capacity of each of the laboratories, also the number of specimens that they receive. So, many of you who followed the South African situation will know that we had a very big backlog at one stage, largely because of the huge community testing program that we had in South Africa. And that really, the turnarounds were up to 2 weeks in some cases, and that really becomes very problematic. I am pleased to say that the turnarounds have come down around the country. I think there is a little bit of a backlog in the Eastern Cape and Gauteng, but I know that is improving. So it's a critical factor. If you're really interested in it, actually the NICD publishes a weekly testing report. It's on our website, and we actually document the number of tests that are done by all the labs and also the turnaround times, from the private and the public sector labs. So you're welcome to go and have a look at that.
Thank you very much, Prof. Let's go back to our online colleagues, and we have David Mckenzie of CNN. Hello, David. Hello, David. I think David is having some difficulties. We'll come back to him a bit later on. But let me come back to the question that we had from Luciano Milala. He had 4 questions initially, and this is the 4th. And Luciano is writing from Mudziwatu Community Radio Station in Malawi. There have been cases of sit-ins and demands of risk allowances by nurses and other government employees. Do you think these demands are realistic? Also factoring in how much African countries have, as well as comparing that with the issue of saving people's lives. Do you think that these demands that are being made are realistic in that context?
So I think it's a very important question, which can only be responded in the context of that country. We don't know the employment contracts and policies that govern such the relationship between those the individuals or the workers doing the sit-in and the government. So it's difficult for me to know that what it is that is causing or that reaction. But all we ask is that our frontline workers are the people that are protecting us, and we should pay particular attention to them and make sure that their working conditions are as best as possible. They are putting themselves on the line to make sure that they treat people that are infected, and by doing so they risk their lives and risk the lives of their families and loved ones. So we should always be sensitive to their needs if they are reasonable.
Thank you for that. Let me try and raise David again. David from CNN. Hello, David. Let me try one last time. David, can you hear us? Okay. While we are still sorting that one out, let's move on to BBC's Peter Mwai. Good morning, Peter.
Well, it seems like we may have lost the Africa CDC, but I think this was scheduled for 1 hour, and the hour is up.
Prof? Hello, Prof. We can hear you.
Just say thank you, everybody, for participating in this event, and we look forward to having weekly updates. So thank you, everybody.
She's still there.
Prof, we are still on. You can stay with us if you can still hear me. Hello, Prof. All right, I think Prof has gone. But let me invite the BBC's Peter Mwai to ask his question. Hello, Peter. Hello, Peter Mwai. Peter, I can see you, but your microphone is muted. Can you unmute your microphone? Peter, please unmute your microphone. And David, if you can hear us, you can ask your question now. All right, it looks like we're not having any luck with our online callers. Let me just make a final check through some of our WhatsApp messages and see if we have any new messages that have come in. Just give me 1 minute. Let me try and find out. All right. We have Modupe Oduloji of Radio Nigeria. And Modupe says, I want to know why Africa is not looking inward for herbal cures or alternative medicines to COVID-19.
I think Africa is open to all solutions. We are, of course, encouraging indigenous groups to come forward. If you recall, I indicated this at the start of this conversation that on the 22nd of July, together with the World Health Organization, the office in Africa, will be launching a regional expert advisory committee on traditional medicine for COVID response. So I think we are inviting you to be part of that as much as well. That is a clear manifestation of our recognition that we have to encourage all our indigenous traditional medicine as much as possible. No one knows where the solution for this will come. We only ask for two things: that when we make claims for any traditional remedies, they should ensure that they are safe and that they are efficacious. That's all we ask for our own indigenous groups. We should hold everybody at the same standards.
All right. Della Russell from Daily Graphic in Ghana says that Ghana, during the early stages of the pandemic, ensured that people under treatment for the virus were tested twice before being discharged for recovery. However, that has been revised, which the government claims was in line with the WHO's discharge guidelines. Now we see a lot of asymptomatic patients being made to undertake treatment at home as a result of the increased numbers in cases. Could this have been a contributing factor to the increased infections? And what will be the Africa CDC's recommendations to the Ghanaian government and other governments in a similar dilemma on the way forward to minimize the spread? That's from Della Russell.
I think that's a very important question, Della. The key thing we, Africa CDC, will recommend is that if we have put out guidelines, those should be followed. If WHO has put out guidelines or guidelines, they should be followed. I think I'm happy that you mentioned that Ghana was following the WHO guidance. That's all I would say at this point. It's very important that we do not provide mixed messages to the countries, that we ensure that countries are following the standard approach as recommended by either the World Health Organization or Africa CDC.
All right. Titi Olademehin of the Voice of Nigeria, do you think it is really safe to reopen the economy by opening schools, markets, and churches? Don't you think Africa should develop its own model guidelines instead of copying what countries in other continents are doing that may not work in Africa, given our own peculiarities?
Absolutely. That's when we produce guidance at a high level, we encourage countries to customize that and adapt it in the local context. I think that is clear. There is no one size that fits everybody. So I think your question is right on the spot. Is what we are encouraging countries to do.
And then the last question for today is coming from Michael Omare from Tunacheki. Does the Africa CDC, together with the African Union, have any funds or programs to support the new industries that have developed in many African countries due to COVID-19? For example, Kenyans manufacturing hospital beds and PPEs, South Africans making ventilators and masks, and Senegal making $1 COVID testing kits and $60 ventilators, among many more.
Now, unfortunately, we, as the African Union, we are not a large funder, so we are not an Africa CDC, so we do not yet have the right funding to support those kind of local manufacturing. But we can advocate for that, and we are doing that to encourage that the right partnerships are established between African manufacturers and those from outside the continent.
All right. Well, thank you very much, colleagues, for having joined us for the past 1 hour or so. And also thank you very much to Professor Lynn Morris, who is the Interim Executive Director of the National Institute for Communicable Diseases in South Africa, and who was our first guest coming from a member state of the African Union. And thank you again, as always, to Dr. John for this press conference that we have every Thursday at 11 a.m. East African time. Join us again at the same time next week. Bye-bye.